welcome to the deep dive. Today we're jumping into a really vital educational summary, Snapshots in Obstetrics and Gynecology. We're treating this as a powerhouse of clinical knowledge, really designed to give you, the learner, all the essential facts you need to quickly get a handle on O&G.
And our mission here is to take this, this dense collection of guidelines and data and really turn it into actionable knowledge. We're going to trace the key hormonal shifts, the diagnostic timelines, and all the critical protocols.
So we're really focusing on the why behind the clinical picture, not just the what.
Exactly.
And we're not just reading from a textbook. The goal is to pull out the biggest pearls that, separate a confident clinician from one who's still finding their feet. So let's start at the very beginning. The hormonal engine of pregnancy, starting with that critical handoff of life support.
That handoff involves the corpus luteum. So when a pregnancy occurs, this structure, which is, normally temporary, it has to be maintained.
To keep pumping out progesterone.
Right, to sustain the early endometrium. And the rescue signal for the corpus luteum is primarily human chorionic gonadotropin, HCG.
So HCG is the messenger, basically telling the body, hey, keep the progesterone factory running. But that's just a temporary fix, right? When does the placenta actually take over the job completely?
Well, the shift is physiological, and it's complete somewhere between 6 and 8 weeks of gestation. At that point, the placenta assumes total responsibility for steroid hormone production.
And the corpus luteum is done.
It begins to involute, yeah. And if that transfer fails, it has catastrophic implications for the pregnancy.
Speaking of HCG, the source material gives us some incredible detail on its dynamics. I mean, it's arguably the most vital lab value in that first trimester.
Oh, absolutely. It's produced by the trophoblastic cells almost immediately after implantation. We can detect it in maternal plasma or urine incredibly fast, about 8, maybe 9 days after ovulation.
And there's an early form, right? Hyperglycosylated HCG.
That's right. It's associated with the really invasive cytotrophoblast cells during implantation. But for clinicians, the numbers themselves,
Right.
they're less important than the rate of change.
The doubling time, that's the surgical red flag in obstetrics.
Precisely. The one piece of kinetics you need to remember is that doubling time. 1.4 to 2.0 days. If the pregnancy is viable, those numbers should be shooting up.
And they peak pretty dramatically.
Very. Around 60 to 70 days. Then they fall off and stabilize. The real takeaway is this. If it fails to double appropriately, that's a sign of serious pathology.
And the really high-stakes application of that is when you have rising HCG, but an empty uterus on the ultrasound.
Yes, that's the classic triad that just screams ectopic pregnancy. Rising HCG, an empty uterus on sonogram, plus abdominal pain and vaginal bleeding, that's a life-threatening emergency.
Okay, let's zoom out a bit to the concept of the maternal fetal placental unit. This is where the biochemistry really dictates fetal health. The placenta can't do it all alone.
It's a beautifully complex partnership. I mean, the placenta, it actually lacks the enzymes for full independent steroidogenesis. For progesterone, it's dependent on the mother.
It uses maternal cholesterol.
It uses maternal LDL cholesterol, converts it to progesterone, but, and this is crucial, progesterone production does not require any precursors from the fetus.
But the estrogens are a completely different story. That's where the fetus comes in.
Absolutely. Estrogen synthesis, especially estriol, which is the most important estrogen in late pregnancy, it does require precursors from the fetal adrenal gland.
Which is why low estriol is such a huge red flag for fetal well-being.
Exactly. It can indicate a whole range of severe issues. Fetal death, adrenal atrophy, anencephaly, Down syndrome, even a hydatidiform mole. It tells you that the critical biosynthetic pathway involving the fetal contribution has failed.
So it's a much more direct signal of acute fetal distress than, say, just monitoring progesterone.
It is, because the placenta can keep making progesterone from maternal sources. Estriol tells you what the fetus is doing.
Okay, so once we've established that hormonal reality, let's look at what the patient is actually experiencing, the classic early milestones.
Well, the symptoms often start with nausea and vomiting. Your classic morning sickness usually starts 1 to 2 weeks after a missed period and then, typically resolves by the 10th or 12th week.
And if it doesn't, if it gets really severe.
Then we escalate the diagnosis to hyperemesis gravidarum. That's when it's causing dehydration and electrolyte imbalance.
And then there are the mechanical symptoms like urinary changes.
Yes, increased urinary frequency is very common. Initially, it's from progesterone's relaxing effect on the bladder, plus the pressure from the enlarging uterus. It usually disappears in the second trimester, which is a relief for many.
Only to come back later.
only to reappear later, yep, as the fetal head engages in the pelvis.
All right, so for clinicians, what are the classic physical signs we're looking for on an exam?
Okay, so the uterus starts pear-shaped, becomes almost spherical by 12 weeks, and then ovoid. We're looking for softening. So Hagar's sign, that's between 6 and 8 weeks, is this marked softening of the lower uterine segment.
Isthmus.
The isthmus, yes, which allows for easy compression. And then Palmer's sign refers to those regular rhythmic uterine contractions you can sometimes feel on an early bimanual exam.
And what about the cervical changes? The color.
Well, Goodell's sign is the softening of the cervix itself by about 6 weeks. But Chadwick's sign is the one you see. It's that bluish discoloration of the vagina and cervix.
Caused by all the increased vascularity.
A massive increase, yes.
But, all of those are presumptive signs. The true, definitive clinical signs involve detecting the fetus directly.
Right. Fetal movement or quickening. A multigravida. A woman who's had previous pregnancies, she'll feel it earlier, around 16 to 18 weeks.
And a first-timer.
A primigravida, typically later, more like 18 to 20 weeks. But the most definitive clinical sign, the one that's undeniable, is hearing the fetal heart sounds.
At what rate?
Beating between 120 and 160 beats per minute, distinct from the maternal pulse. That's when you know for sure.
Okay, once we've tracked these physical signs, the next step is formal surveillance, making sure the fetus is okay.
And for that, in the first trimester, transvaginal ultrasound, or TBS, is superior. It's the most accurate way to confirm an intrauterine pregnancy and get the gestational age right. It can detect signs about a week earlier than a transabdominal ultrasound.
Then later in the pregnancy, we start using tools like the Biophysical Profile, the BPP.
Right, usually after 28 weeks. The BPP is a really powerful snapshot. It's a composite score, max of 10 points across 5 components.
And those are?
The non-stress test, fetal breathing movements, gross body movements, fetal tone, and the amniotic fluid volume. Each is worth 0 or 2 points.
And the score itself dictates what you do next, which is critical for junior clinicians to know.
It is. A score of 8 or higher is reassuring. You just continue routine monitoring.
Okay.
A score of 6 or 7 it's equivocal. It's concerning. You'll probably repeat the test within 24 hours.
And a low score.
A score of 4 or less is profoundly non-reassuring. That signals potential fetal compromise, and immediate delivery is very strongly suggested.
But before we even get to the BPP, there's screening with biochemical markers, the triple screen.
The triple screen, yeah. Done between 15 and 20 weeks. It measures 3 things. Maternal serum alpha-fetoprotein, or MSAFP, HCG, and unconjugated estriol.
And you're looking for a specific pattern.
Exactly. For Down syndrome, for instance, you're often looking for a trifecta: low MSAFP, low unconjugated estriol, and a high maternal serum HCG. If the risk comes back higher than, say, 1 in 250, then you offer definitive diagnostic tests.
Like an amnio or CVS.
Amniocentesis or chorionic villus sampling, correct.
One last thing on antenatal care. Maternal weight. This is so important and so individualized.
It is, and it's all based on the pre-pregnancy body mass index. For a woman starting at a normal weight, a BMI between 19.8 and 26, the recommended gain is about 11.5 to 16 kilograms, so 25 to 35 pounds.
But for a patient with obesity?
A totally different story. If their BMI is over 29, the recommended gain drops dramatically, less than 7 kilos or under 15 pounds. It requires really specific counseling.
This all leads eventually to labor and delivery. Let's quickly walk through the 4 stages.
Okay. Stage 1 is cervical defacement and dilation. Stage 2 is the actual delivery of the fetus. And this stage has different expectations, roughly 50 minutes for a primigravida versus maybe 20 for a multigravida.
Then stage 3.
Delivery of the placenta, usually about 15 minutes for both. And stage 3 is that critical 1-hour observation period right after delivery.
Watching for bleeding.
Watching for stability and bleeding risk, yes.
Now let's talk about when things go wrong. Obstructed labor is a huge one.
It's one of the most critical complications, and if it's neglected, the dangers escalate fast. For primigravida, the primary maternal risk is often pressure necrosis of the tissues, which can lead to genitourinary fistulae.
And for a multigravida?
The main danger is a catastrophic uterine rupture, especially if there's a previous C-section scar.
And for the fetal?
The fetal complications are profound: asphyxia, acidosis, and even intracranial hemorrhage from the extreme pressure.
This leads to probably one of the most important clinical rules in all of obstetrics.
Absolutely. Oxytocin must never be used to stimulate contractions if you even suspect obstruction. You're basically adding fuel to a fire when the exit is blocked. It vastly increases the risk of uterine rupture.
When labor can't proceed, We turn to operative delivery. For a cesarean section, what's the plan for post-op fluid management?
The focus is stabilization. So the rule of thumb is replacing about 3 liters of IV fluids during that first day, but you have to monitor closely. You want to see a urine output of more than 30 milliliters per hour.
And the catheter.
In an uncomplicated case, you want that urinary catheter out within 12 hours post-surgery to minimize infection risk.
All right, shifting gears to high-risk obstetrics. Let's talk twins. How is the management for the second twin so complex?
Well, delivering that second twin requires a very quick, very complex assessment. It's all based on its presentation, its position, and its estimated weight. You might proceed with a second vaginal delivery, or do a breech extraction, or even an external cephalic version.
Or just go straight to a C-section?
Or proceed directly to an emergency C-section if there's any sign of malpresentation or distress. It's a very dynamic situation.
What about a transverse lie, where the fetus is just positioned sideways?
So a transverse lie is a clear contraindication for vaginal delivery. During the pregnancy, you might try an external cephalic version, an ECV, to turn the baby. But if that fails, or if the patient is in labor, it's an elective or emergency C-section.
And if it's neglected?
It leads straight to obstructed labor, uterine rupture, and all the complications that come with it.
Okay, let's clearly differentiate 2 major causes of obstetric hemorrhage: placenta previa versus placental abruption.
The key contrast is timing and pain. Placenta previa is when the placenta covers the cervical os. It typically presents as painless vaginal bleeding in the 3rd trimester.
And the absolute non-negotiable rule with previa
is that a vaginal examination is strictly avoided. You can provoke immediate torrential bleeding. Management is all about stabilization and a planned C-section.
and abruption, the hidden danger.
Placental abruption is the premature separation of the placenta from the uterine wall. This presents with dark red vaginal bleeding combined with pain. The uterus is often rigid, tense, and tender.
And the treatment.
Definitive treatment for a severe abruption is immediate delivery, almost always by emergency C-section, especially if there's fetal distress.
That was an intense run-through of obstetrics. Let's finish with some key snapshots from reproductive health, starting with amenorrhea.
Right, the absence of menstruation. We classify it as primary, never having menstruated, or secondary, which is the cessation of periods for 6 months or more. And we think about the cause based on 4 functional compartments: the outflow tract, the ovaries, the pituitary, and the hypothalamus.
And managing it is about more than just fertility, right?
Oh, absolutely. The goal is preventing long-term complications. You have to prevent osteoporosis from chronic estrogen deficiency, and you have to prevent endometrial hyperplasia if there's unopposed estrogen.
Moving to infertility, let's touch on IVF. What are the main indications?
In vitro fertilization, or IVF, is indicated for patients with damaged or absent fallopian tubes, severe endometriosis, and severe male factor infertility, like severe oligospermia.
And the process is pretty structured.
Very. It's 5 major steps: ovarian stimulation, follicular aspiration, sperm preparation, fertilization, and embryo culture, and then finally the embryo transfer.
We'll wrap up with contraception, specifically the combined oral contraceptive pill, the COCP. It has a powerful triple mechanism.
It does. It works by 1, preventing ovulation entirely. 2, it thickens the cervical mucus, making it a barrier to sperm. And 3, it alters the uterine environment to prevent implantation.
And there's a big non-contraceptive benefit that we should always mention.
A very significant one. It has a protective effect against ovarian, endometrial, and possibly even colorectal cancer.
But the critical limitation, the counseling point you can never, ever skip.
They offer 0 protection against sexually transmitted diseases or HIV. Barrier methods are still absolutely required to address that risk.
Okay, so let's try to synthesize all of this. What really stands out is that O&G forces you to connect knowledge from the molecular level like steroid precursors directly with critical tools like the BPP score.
Yeah.
You have to think small and big at the same time.
It's the ultimate integrative specialty. I mean, you need to know the molecular pathway that leads to low estriol, and you need to know the emergency protocol for a BPP of 4, all while managing the real-world chaos of a delivery room.
So to put that integration to the test for you, we have a quick review exercise based on that BPP scoring protocol we just discussed.
All right. A 34-week pregnant patient with severe preeclampsia undergoes a biophysical profile. The results are: she scores a 2 for fetal breathing movements, a 0 for gross body movements, a 2 for fetal tone, a 2 for the non-stress test, and a 2 for amniotic fluid volume.
Your exercise is this. Calculate the total BPP score. And based on the protocol we covered, where 8 is reassuring and 4 or less means delivery, What is the immediate management recommendation for this patient?
And here's a final thought for you, building on that hormonal pathway we talked about. If the placenta relies only on maternal LDL cholesterol for progesterone, what is the crucial precursor step that the fetal placental unit has to perform to successfully produce the late pregnancy estrogen, estriol? Think about the specific fetal organ and the molecule it provides.
We hope these deep dive snapshots help you integrate these critical distinctions and feel a little more equipped for your next clinical challenge.